Welcome to AETCM, the Emergency Medicine Channel. Started. 56-year-old man presented to ER with alleged history of deliberate self-harm of ingestion of organophosphorus poisoning 5 days back. On initial and referred here, on initial 10-second assessment, airway was secured by endotracheal intubation from outside the hospital and referred here. And breathing part, bilateral crux was present, iron bilaterally equal, respiratory rate is 22 per minute, and SpO2 is 99 on FiO2 of 40. Circulation part, BP is 150, 70, and heart rate is 115 per minute. Disability part, E1, VT, M1, peoples are bilaterally equally dilated, non-reactive. Exposure part temperature was 100 degree Fahrenheit. Adjoint to primary survey.
So, this patient used OP poison 5 days back and was treated, initially managed in outside hospital and now came here.
Yeah.
Okay, so with this primary survey, what all things will you suspect?
By an airway it was secured, and by breathing part there is bilateral crux was present. So we know the patient has taken OP poisoning, and we understand that atropine will be give continuous infusion needed for that patient because crux was there. Then other thing, circulation part BP was 150 and heart rate is also tachycardia is there. So atropine is action is there, and exposure temperature was there. So we also suspect any ventilator associated or hospital associated pneumonia also we will suspect for this patient.
Okay, and also since this patient is sedated, we won't be able to assess the sensorium. But in case of hyperthermia, we need to suspect atropine poisoning, overdose, or toxicity also. So this patient we will have to also check for the bowel sounds to see whether it is absent or not. Okay, so suppose if you are getting an information that they are shifting somebody is shifting a OP poison patient which was used today. So what all things will you prepare in the ED?
First of all, we will wear personal protection equipment. Then we will prepare
what all things? Personal protective
face mask, gown, gloves.
What gloves? What type of gloves? Usually, if we have latex gloves, we are not supposed to use that. We are supposed to use nitrile gloves. Why we are using all the personal protective equipment?
Because absorption through skin is very...
Absorption through skin, inhalation is also there. Okay. So, those personal protective equipment should be ready, and a decontamination room also should be kept ready. Patients, so anyway, our management will be airway, breathing, circulation, but decontamination also should be done as a part of B. So, airway, what all things can go wrong?
Airway, respiratory, by it has two action, muscarinic and nicotinic action. By muscarinic action, it will increase the bronchial secretion, bronchuria, and by nicotinic action, CNS action, it will cause us respiratory center weak, respiratory center. Then respiratory center affect and causes respiratory failure also. So by both action, patient will go into respiratory insufficiency and failure. So we will
and respiratory muscle paralysis also.
So we will protect the airway immediately.
If the airway is not secure, airway should be protected. And another thing is it will cause CNS depression. Sometimes patient might have agitation, seizure, coma, and also airway. That is the importance of airway. So we will have to arrange for all the airway equipments also before the patient comes. Then breathing.
Breathing part also there is a chance for PCOT build-up, desaturation.
Because of
respiratory failure and respiratory weakness, muscle paralysis
and bronchuria.
Breathing part, nebulization. If V's is present, we can give nebulization also.
We are not expecting V's here, so we are expecting respiratory secretions here, and we are suspecting a bradypnea. Sometimes patient might be in bradypnea because of the muscle paralysis. So we will have to prepare for the anyway. If you are securing the airway, the ventilator support and rest of the things, and atropine. For reversal of action. Okay.
Patient is coming within 1 hour. First of all, we protect the airway. Then we can give oral activated charcoal.
That is after that. That is after the primary survey. So we have reached airway, breathing, circulation.
Circulation part. Normally, in 80% of patients, we can see tachycardia. bradycardia, in 20% because of the sympathetic action, nicotinic postganglionic receptors there causes tachycardia. So bradycardia, we can that also we can manage with atropine, and if there is if atropine is not acting, we can add on with epinephrine for bradycardia also.
Okay. Then D.
The disability part, we will look after the GCS. If low GCS, we will anyway secure the airway. Or if the patient is maintaining GCS also, if there is evidence of organophosphorus with high dose intake, better to secure the airway because patient will later deteriorate.
Okay, so if we are planning for a rails tube insertion and gastric lavage and also, so that itself can cause emesis. This patient is having a high chance of emesis. So secure the airway first and then plan on doing gastric decontamination. Okay, and D is decontamination.
Decontamination, we can thoroughly irrigate the patient and remove the clothes and wares and keep it for forensic evaluation and thoroughly irrigate the
in
patient.
A closed bag.
And also eye irrigation also do.
Okay, so clean with soap and water the entire body. And one thing we used to miss is that this patient, whenever this patient goes to ICU and all, so that patient might not have passed stools in the ED. After 4 or 5 hours, patient might be shifted to ICU and their patient will pass stools. That time also we need to use all the personal protective equipments while cleaning that. Okay. All the body fluids and contents, if the patient vomits, these things and all should be dealt with proper precautions. Okay. So what is the mechanism of action of organophosphorus?
Organophosphorus mechanism of action, it will inhibit the acetylcholine esterase enzyme, which will metabolizing the acetylcholine. So it will inhibit the enzyme action, causing increasing the amount of acetylcholine in the postsynaptic synapse.
Okay.
Causing cholinergic crisis. Organophosphorus.
Then what are the symptoms?
Symptoms will lead to acute cholinergic crisis. It will mnemonic is sludge and triple B, salivation, increased salivation, lacrimation, urination, defecation, gastric emesis. Then triple B is bronchorrhea, bradycardia, bronchospasm.
And some muscarinic action.
Muscarinic action. In some patients, 20% patients, we can get tachycardia because of the sympathetic stimulation by the nicotinic receptors. And nicotinic action, this is muscarinic action. Nicotinic action, CNS action causes drowsiness, coma, seizures, and respiratory center failure. And respiratory muscles action causes fasciculations, weakness, and paralysis. And respiratory causes respiratory muscle weakness, respiratory failure.
Along with tachycardia, we can expect hypertension also, high BP, hypertension also. Then stomach.
Stomach increase the gastric acid production, increase the gastric motility, and
also there is chance of sometimes pancreatitis. These issues can be there. In the lungs.
And lungs causes bronchorrhea, bronchoconstriction, bronchospasm.
Then some of the organophosphorus will contain hydrocarbons in it. That can cause chemical pneumonitis, lipoid pneumonia. This patient came anyway after 5 days. So in this patient, along with ventilator-associated pneumonia, we need to suspect lipoid pneumonia also.
And cardiac issue causes bradycardia and hypertension, and sometimes tachycardia and hypertension, and also some patients causes MI. With ECG changes with troponin positive, we take as NSTEMI or STEMI. In some nicotinic receptor causes myocardial infarction also.
Then sometimes we can see ventricular tachycardia, torsades de pointes, arrhythmias also can happen. Okay. So this patient came after 5 days. Okay. So already intubated from outside. What you have found is that this patient is having bilateral crepitations, fever is there, and tachycardia. Okay. How did you go ahead?
In this patient, primary survey, primary survey, we will take an ABG. ABG was normal. pH was 7.43, PCO2 40, PO2 80, and Bicon 22. Then we send a routine lab investigation, and like 5 days, we will suspect patient will go into intermediate syndrome. So we send a lab RBC acetylcholine stress level also.
Okay. What cholinesterase will it inhibit the OP poisoning?
True pseudocholinesterase.
True is not pseudocholinesterase.
Yes, true cholinesterase.
True cholinesterase. So, true acetylcholinesterase enzymes will be inhibited, or RBC cholinesterase. What is pseudocholinesterase?
Pseudocholinesterase seen in plasma.
Plasma. So, that is seen in plasma or in the liver, kidney, liver, pancreas, stomach, brain, and all. Okay. So, now what will OP inhibit?
True acetylcholinesterase.
RBC cholinesterase. Okay. So, is it reversible inhibition or complete inhibition?
OP poisoning causes irreversible inhibition. Then carbamide causes reversible inhibition.
Okay. So, this you are talking about intermediate syndrome. So, intermediate syndrome happens when?
After 1 to 4 days, a patient will go into intermediate syndrome.
That is because?
That's because of one is lipophilic organophosphorus causes fat distribution, and after 1 to 2 days, the release from to return to plasma, it causes causes weakness, neck flexion weakness, respiratory muscle weakness, deep tender reflex absence. That is.
So usually what is happening is carbamate, as you told, it will cause a reversible inhibition of the acetylcholinesterase enzyme, whereas OP will cause an irreversible binding. So after some time, if we give the antidote as early as possible, atropine and pralidoxime, we will be able to reverse that. But if we are giving it very late, it will go for an irreversible binding with the acetylcholinesterase enzyme. So that can cause a tendency for intermediate syndrome, because there is it has formed a irreversible binding. And the problem is it is RBC cholinesterase. RBC will be regenerated only after 120 days. So that is a problem. Whereas in plasma, cholinesterase will be made after few days. So, so that will have a tendency. And another thing is that whatever, as you told, whatever OP has been distributed to the fat will act as a poison again after 5 days. That will cause intermediate syndrome. So, what are the symptoms?
Symptoms patient had in intermediate syndrome, patient had proximal muscle weakness, again respiratory muscle weakness, respiratory paralysis, neck flexion weakness, loss of deep under reflexes.
Then all the muscles supplied by the cranial nerves also will be involved. Okay. Well, what other syndromes can happen secondary to OP?
Intermediate syndrome, then after 2 to 3 weeks, it goes to delayed OP poisoning induced neuropathy. Delayed neuropathy, it is presented with distal muscle, more likely distal muscle weakness with sensory weakness also. Patient presented with the food drop, clinically, patient with food drop.
Mostly like a Guillain-Barré syndrome, food drop, absence of reflexes, and sometimes sensory loss also can be there in delayed polyneuropathy. And patients who are having chronic exposure to OP, like farmers and all, can have chronic fatigue syndromes. Okay. So this patient ABG was taken, then what else was done?
ABG was taken, then we send the RBC cholinesterase level. Then we suspecting intermediate syndrome. We will first of all done a neuroconduction study also. Neuroconduction study.
So what was the cholinesterase level this patient?
Less than 400.
That was low. Okay.
That's low. Then neuroconduction study was done. That's showing low firing of the action potential of motor and sensory system. So diagnosed as intermediate syndrome patient, intermediate syndrome.
Okay.
Also, we will take an MRI stroke protocol to rule out any stroke affected. MRI protocol is normal.
What was the cause of fever for this patient?
One is ventilator because 82 bronchial lavage showing Pseudomonas aeruginosa. Then other is patient was on atropine infusion while shifted. So
how was the X-ray and all? Was there any pneumonic patch?
Pneumonic patch is there.
Okay, so that is there. So patient is in intermediate syndrome along with VAP. Okay. Okay.
Then we diagnosed intermediate syndrome. Then we started on.
No, you can. Anyway, we got some impression after that is initially after the primary survey, our role is to take an ABG, chest X-ray and all. Did you tell about the sample history?
56-year-old male patient, known case of diabetic hypertensive. He was missing from his home since that day morning and found to be lying on nearby field, unconscious and frothing from mouth with bowel and bladder incontinence. Then suddenly they taken to the Oxford hospital. On examination, that hospital patient pupils is constricted, and in view of low GCS of E2, V2, M4, patient was intubated and sedated, and then started on atropine and pralodoxim infusion. On day 5, while the acetyl cholesterol level is less than 200, they shifted the patient to here.
Okay, so what is the dose of atropine will you give in OP poisoning?
Atropine, we can give bolus dose of 1 to 2 mg IV bolus we can give, and repeat every 3 to 5 minutes, and check for
Not 3 to 5 minutes, from 5 minutes to 15 minutes.
15 minutes. Then we can give the bolus up to patient bronchial secretion, bronchuria decreasing. Then if it is get better, we can start on IV infusion with 20 to 10% of the cumulative bolus dose.
Okay.
We can start on the infusion dose, and we can continue the infusion up to the atropine side effects affecting. Side effects like agitation, drowsiness, absence of bowel sounds, urine retention. If there is any side effect affected, we can stop the atropine for 1 hour, and we can start on atropine again infusion after 1 hour with 70% of the infusion dose.
Okay. If a patient is having CNS symptoms secondary to atropine, what is the other alternative?
Can with glycopyrrolate with 1 ml containing 0.2 mg. 0.2 mg.
Usually glycopyrrolate will come as an ambule. It will contain 3 ml. So 3 ml will contain 0.6 mg. Okay. What is and CNS effect will not be there for glycopyrrolate. So if you have atropine and you don't have any IV cannula, what is the IM dose of atropine which you can give? 2 to 6 mg can be given as IM, intramuscular dose. Okay. Now, then what happened? Then pralodoxim was started.
Pralodoxim we can give.
What is the mechanism of action of atropine in OP poisoning?
Atropine is a competitive antagonist of acetylcholine. It will bind on the muscarinic receptor in competition with acetylcholine, and it will reverse the
effect. Okay. What about pralodoxim?
Pralodoxim. We can start with 30 mg per kg IV.
And what is the mechanism of
action? It will prevent the aging. Aging means reversible binding.
Prevent the irreversible binding of the acetylcholine. Okay, estrase.
And pralodoxim we can start with 30 mg per kg IV bolus for 30 minutes. Then we can followed by infusion of 8 mg per kg.
Per hour infusion. Okay. How many days you'll have to give pralodoxim?
Pralodoxim maximum 24 hours after
24 to 48 hours you can give. Okay.
Some if the agent was like lipophilic agent, we can continue the pralodoxim because of the we can
slow release. Okay. Then what else was done?
Then you can start on anti-seizure medication.
Suppose this patient took carbamate, will you have to give pralodoxim?
No, pralodoxim.
It is reversible binding, but there is no harm if the patient, suppose just imagine a patient came with OP with carbamate injection. Will you give? Yes. So there is no harm in giving pralodoxim in carbamate overdose. Okay.
Then we can, if the patient will goes into any seizure, we can start with anti-seizure medication. Better to start with benzodiazepine. Avoid phenytoin because phenytoin has no effect in study. Showing phenytoin no effect.
Okay. And then and intubation drugs.
Intubation drugs better to avoid succinylcholine because succinylcholine causes inhibition of the acetylcholine esterase enzyme. So it will again act the action of the cholinergic crisis.
Okay.
So better to start with a non-depolarizing agent like rocuronium.
Okay. So that is about the OP poisoning management. So this patient right now we have diagnosed from the evaluation done and examination. Anything was there? System examination.
Systemic examination. Patient was sedated with chest findings is there. No other findings.
Okay.
Just normal limits.
Okay, so this patient, we got the history, and from our evaluation, we found that the cholinesterase level was still low. Patient had Pseudomonas aeruginosa infection and also acute intermediate syndrome. Okay, what was done?
For this patient, we will, because of the prolonged intubation, we will plan for percutaneous tracheostomy. It was done, and for intermediate syndrome, we started on physiotherapy. Now patient was done.
So suppose this patient before tracheostomy, this patient was received in the ER with on a ventilator. So suppose this patient starts desaturating. How will you assess the patient? How will you find the cause of desaturation?
First of all, one is we can suction the ET tube to decrease any blockage of the ET tube.
Now, what all things will you suspect in a patient who is on ventilator who is desaturating? Any patient, not only OP poison, any patient.
One is if referred patient, we will first assess the ET tube is in proper placement. Is there?
That is displacement.
Displacement and blockage.
How will you check that?
If the patient is sedated, we can do with laryngoscope. We can or we can keep it CO2 if there is.
No, simple thing what you can do,
Auscultation.
Auscultate all the 5-point auscultate, and we will be doing. Then we can do the ETCO2 and if you have a doubt, you can scope and do. That is the displacement. Then
look after any blockage of the ET tube to suctioning done. Then any disconnection.
Pneumothorax.
Otherwise, more directed to right side also.
That is displacement. Then pneumothorax you will check. Then equipment failure. Then one more. Auto PEEP. Okay. Then also breath stacking, like patient will be taking against the ventilator, that itself can cause this thing. So in that scenario, we will have to increase the sedation, or if the patient is agitated and all, we will have to give benzodiazepine something. Okay. Okay, so this patient was planned on tracheostomy. Okay.
After tracheostomy, we will give PMR consultation also. Physiotherapy was done after tracheostomy. Patient now maintaining in room air saturation of 99.
Oh, so with physiotherapy. Okay, so was atropine continued for this patient?
Atropine continued for for 1 week. We continued the atropine and later with
atropine infusion.
Infusion.
Okay.
Then we changed the atropine to glycopyrrolate also, to any sensorium is improving, to know that we changed to glycopyrrolate, and also to decrease the secretion also we changed to glycopyrrolate. Then after 1 week we stopped the atropine and glycopyrrolate.
So was oximes given from here, or
no, oxygen from outside?
Was only given from outside. This patient came after 5 days.
No.
Okay, so atropine was continued, then was changed to glycopyrrolate. How was the sensorium of the patient after tracheostomy?
Not fully improved. Still on.
Was patient obeying command?
No, ma'am.
Okay. And physiotherapy also was started. Okay, what antibiotic was started for this patient?
Started Pseudomonas piptas. Already piptas was culture sensitive, so we continued the piptas.
Okay. What else we will have to look in the ICU, this patients? Any patient in ICU on ventilator? Thromboprolysis. Then?
As to bowel
movement with personal protective equipment. Okay. Then bed sores should be checked, because this patient is on ventilator for many days, supine position, and also check for the indwelling catheters, whether they are getting infected or not. Okay. Anything else? So right now the patient's ventilator associated pneumonia is being managed with the antibiotics, and glycopyrrolate was given, and once the effect of poison got over, for further physiotherapy and management was referred to PMR. Right? Anything else? Okay, thank you.